Hello, everybody. I see we have participants joining the room. Good afternoon, and welcome to the first session of training series implementing medication-assisted treatment in recovery residences in Pennsylvania. My name is Jenna Nesbitt, and I work for the Center for Social Innovation. I am a recovery specialist. This event is brought to you by the Substance Abuse and Mental Health Services Administration's Opioid Response Network and Pennsylvania's Alliance for Recovery Residences. Our TA Center is dedicated to increasing access to recovery supports, and we achieve this work through a variety of mechanisms, including a lot of TA focus on systems transformation and developing the capacity of peer-run recovery communities and family and youth-led organizations. I am pleased to introduce to you today Jennifer Ria. She is also a recovery specialist at Center for Social Innovation. She also works on the Opioid Response Network. She'll be talking to you about the science of addiction. I'll be turning things over shortly, but first I'd like to review a few housekeeping rules with you all. Please remember to mute your speakers. If you are calling in to the webinar, and remember to mute your microphone. The computer speaker can be muted by pressing on the green horn at the upper left corner of your monitor. And it is just above the headshots of the presenters. If you have any questions during the presentation, you can use the chat and questions box down on the bottom left. If we have time at the end of this session, we will answer some questions. Any remaining questions that we don't get answered, we will answer at the beginning of the second session if we run out of time today. We have also put some resources for the webinar in the download box, and it says Webinar Resources box. To download a file, click on the name of the document and then click Download File. This event is being recorded, and the recording link will be shared with all registrants after the event. You'll be able to review the chat and rewatch the presenters using this link. And so with that, if you have any additional questions, please put them in the chat box. Also, please consider reaching out to request technical assistance for any opioid response requests that you have. Thank you for joining us today, and have a great time. Jennifer?
We're excited to have everybody here. So I am going to be speaking today about the science of addiction. We're going to spend some time talking about the disease itself and the medications used to treat it. And so as Jenna mentioned, this is part of SAMHSA's State Targeted Opioid Response Network, and we assist grantees, individuals, and other organizations by providing resources and technical assistance locally to address the opioid crisis. And if anyone on the line, or if you're aware of any technical assistance that is needed, it is available to support evidence-based prevention, treatment, and recovery of opioid use disorders. And if you have any questions or would like to submit a request for technical assistance, within the webinar and the presentation itself, there is a link here to visit opioidresponsenetwork.org, or you can email or call to request technical assistance. So we're going to go ahead and get started today with the science of the disease of addiction. We're very excited to have conversation about this topic. As Jenna mentioned, if you have questions or if you have any comments that you would like to contribute, please feel free to do so in the box called Chat and Questions. And as Jenna said, if we have time at the end of today's session, we will address and answer questions. If we don't, then our plan is to take those questions into the second session and address those before we get started on the second topic in the series. So hopefully everyone will be available to join us for the next session as well. All right, so the first thing that we want to talk about today is some of the myths and facts related to addiction. And I'm sure that many of these myths will not be new to you. Many of you have probably heard many of these things yourself, either in your communities, maybe even in the recovery community that you're a part of. So the first is that addiction is a bad habit. It's the result of moral weakness, overindulgence, bad decision making. And if an individual has enough willpower, they can stop using alcohol, they can stop using drugs. It's simply their choice. Another sort of opposite myth that you hear is that people relapse. People know people who have been through rehab or treatment many times over and over, and they relapse. So clearly treatment doesn't work. Clearly it's not something that's actually effective or actually medical treatment. So what do we think about those myths? What are the actual facts? So the facts are addiction is a disease. It can be chronic, meaning it can keep coming back. It can continue for long periods of time. It can be life-threatening. It's like heart disease, such as clogged arteries, high blood pressure, diabetes, and we'll talk more about that here in a minute. Another fact is that due to physical changes within the brain itself, most people cannot simply stop using, no matter how strong their inner resolve or their commitment to sobriety is. We're going to talk more about why that is as well. And then the last fact is that, like virtually any other medical treatment, addiction treatment does not guarantee lifelong health, does not guarantee the addiction will not come back, does not guarantee that the disease will not reoccur. And I like this discussion here from the New England Journal of Medicine that talks about addiction as a disease like other medical conditions in which voluntary, unhealthful behaviors contribute to disease progression. For example, heart disease, diabetes, chronic pain, lung cancer. And so the thing that we know is that the fact that these diseases are exacerbated by these unhealthful behaviors and that changes in behavior, if you just exercised more, if you just chose to eat differently, if you just stopped smoking, if you just did more things to stretch and get exercise to help your pain, those things would help the disease. But that doesn't make it less of a disease. It doesn't make those things like heart disease, diabetes, lung cancer, doesn't make them not a disease. It doesn't make them not a medical condition. And just the same way, addiction is a disease that is exacerbated by voluntary unhealthful behaviors, but it is still a medical condition that needs medical treatment. So what we want to look at here to start with is how the disease of addiction works and what it actually does to the brain. So the brain is a system of neurons that is constantly sending and receiving information back and forth. And in between the receptors that are sending and receiving the information, there are little packages of information, and these are called neurotransmitters. And the neurotransmitters transmit all the information that our brains use 24 hours a day to tell our bodies how to function. Everything from processing what our eyes see, processing what we smell, telling our lungs and our heart to keep working, recognizing pain, danger, pleasure, all those things. There are little messages going back and forth between all the systems of receptors in the brain. And some addictive substances, such as opiates, get picked up as neurotransmitters, specifically pleasure message neurotransmitters, and they get communicated in the brain in such a way that they trick the brain into needing the addictive substance just to maintain the balance that the naturally occurring pleasure neurotransmitters would have been sending back and forth. And the addictive substance messages can be 2 to 20 times more potent or more powerful than the naturally occurring pleasure neurotransmitters. So then what happens is that with time and repeated overexposure to these addictive substances, the neurotransmitters associated with pleasure cause the brain to try and rebalance itself. And it does that through one of two methods. It either starts to reduce the number of receptors that are in a person's brain that can accept and send the pleasure message because the pleasure message is so overpowerful, or it tries to rebalance by producing fewer and fewer naturally occurring pleasure neurotransmitters. So what that means is that the person's new natural state underneath that addiction is now what would feel like flat or depressed, and the only way that they can feel normal, or the only way for the brain to feel balanced, is to have that substance that's now sort of that synthetic pleasure neurotransmitter, and the brain has now reprogrammed it to need it. And so at this point, the brain has actually begun to rewire its internal messaging system, and then that begins to impact memory, how you experience and decipher pain, the ability for rational decision-making, self-regulation, including mood control, self-control, and all of the problems that we often see in a person who has active addiction. These things are usually happening because the brain has begun to rewire itself because of that overabundance of the neurotransmitter, the pleasure opioid transmissions. And so the messages regarding the brain's need for the alternative or the overproduced pleasure neurotransmitters are taking over all other messages that are trying to be transmitted within the brain. So trying to access memory, trying to accurately decipher levels of pain, trying to make good decisions, all of that is being overridden and being muted because of these pleasure messages and the need for those pleasure messages that's happening back and forth within the brain's receptors. And so what we want to look at is that we can actually physically see this happening in people's brains, that this is not theory, this is not hypothetical. We can actually see the changes in a person's brain over time with using these addictive substances and what it physically does to the brain. So if you would look at the left side of the screen, there is a picture called dopamine D2 receptors are lower in addiction. So on the far left, we have a series of brain images, and these are images of people who are not addicted to a substance. And what you see is what lights up or what happens within the brain when these people are exposed to something that should give a human pleasure. So food that tastes good, picture of a loved one, a smile, something that should cause a pleasure message, a happy message. What happens when you put that in front of a person who does not have addiction? And what you see is you see these little red areas light up, and that's their pleasure receptors reacting. What you see on the right is a person who has addiction to a substance, and what happens when you show them or expose them to those pleasure-inducing things, good food, pictures of a loved one, something that should cause happiness or pleasure. And what you can see is that the amount of pleasure receptors reacting to those pleasure-causing triggers are either almost non-existent or minuscule. And so what you see if you look at that top one, the person with an addiction to cocaine, the next one, a person with an addiction to meth, alcohol, heroin, you can physically see that when exposed to things that should cause pleasure, the brain simply isn't reacting. And this is what we were talking about, that these people's natural state, their brain has rewired itself to completely mute, turn off the ability for natural pleasure because of the overexposure to these neurotransmitters, these synthetic substances, where the opiates or the drugs are replacing the pleasure transmissions going back and forth. So you can physically see the impact that the addiction has had on their ability for the brain to even interpret a natural pleasure sensation. The other thing that happens over here on the right-hand side, if we look at this MRI scan, at the top you have a control subject, a person who does not have addiction, and then a person at the bottom who has an addiction to alcohol. And so what you see is a significant difference between the size of their ventricles and the frontal lobes. And in the very top one, the ventricles are look like small little slits here. And then in the lower ones, they're much larger. Now what ventricles are they're open spaces for fluid to communicate within the brain. They don't do any brain thinking, functioning, sending messages, things like that. And so what this means is that there is less brain matter that does thinking, functioning in the frontal lobe of this person or of people with an addiction to alcohol than there are for the person who does not have an addiction. And so what happens is that the addictive substance actually causes decrease in functional brain matter, the brain matter that controls your decisions, the brain matter that helps you function throughout daily life is actually decreased by the overexposure to the addictive substances. And the interesting thing is that the decline in gray matter, the decline in brain matter that's functional is most pronounced in the frontal lobes, which you may know is where decision-making, reasoning, judgment happens. And so what we want to make sure that people understand is that the idea of addiction as a disease is not a theory. It's not something that's just an idea. You can actually see it on people's brain scans. You can see the impact of these substances on the organ itself. And so one of the other questions that sometimes comes up is, why are some people or why are certain people more vulnerable to addiction? Why does it seem that some people become addicted more quickly? Why does it seem that some people have a more severe addiction very quickly than other people? And as you might expect, there are certainly some environmental reasons, but there are also some biological and genetic reasons. And so one of the things that we know is that people who have a family history of addiction are more genetically predisposed to have a more severe addiction or become addicted more easily or more quickly than people who do not have that history. Additionally, we know that there are developmental reasons, and this could be experienced or observed. And by experienced, we mean if your brain is exposed to addictive substances while you're in utero, while you're a child, while you're an adolescent, it increases the vulnerability to addiction later in life. And then observed developmental vulnerabilities is when we're talking about if you observe while you're a child, while you're an adolescent, adults in your life with addiction, with substance use disorders, who are using substances for coping, who are addicted, and that seems like a common thing or a normal thing in your life, then whether you recognize it or not, you have developed more of a vulnerability to addiction yourself when you begin to use those substances. Additionally, people with chronic pain have a greater vulnerability to addiction. And again, this has a physical component, a biological component. And the reason is because pain messages are also neurotransmitters going back and forth in the brain. And when there's chronic pain involved, the pain messages are also reinforcing that message, asking for the addictive substance to reduce the pain. And that's on top of the messages that are going back and forth because of the addiction, just asking for the addictive substance. So people with chronic pain, it's even harder for them to just voluntarily stop because they have even more messages going back and forth in the brain, overwhelming all other function that's happening up there, asking for the addictive substance. The other thing that we know is that some other mental illnesses impair the same messaging systems and the same communication systems that are impacted by addiction. And so individuals with certain mental illnesses may also be more physically susceptible to addiction because of this impairment. Additionally, people with mental illness may also be motivated to use substances even before they're physically addicted as a way of self-medicating symptoms of mental illness. And you may see this in individuals with hallucinations or psychotic disorders, schizophrenic disorders, where in order to mute the hallucinations or mute the delusions, they may use substances as a self-medication, and that then makes them even more vulnerable to developing an addiction on top of the mental illness they may already have. So one of the other things that we want to talk about is what are triggers, what are cravings, what are the physical, biological aspects of relapse. And so what we see is that even after detox happens, even after these addictive substances are no longer physically in the brain, are no longer physically in the body, people still experience physical symptoms of addiction. Why is this? And so one of the examples that we like to point to or talk about is the example of Pavlov's dog. You may have heard about this in school. So Pavlov was a scientist who trained his dog to salivate every time he rang a bell. And he did that by, he would ring the bell, give the dog a piece of meat. Ring the bell, give the dog a piece of meat. And the dog's brain associated, ring the bell, I get something pleasurable. And so the bell itself became the trigger for the pleasure sensation, or the looking for the pleasure sensation to happen. And so the dog would physically salivate, waiting for that pleasurable thing to happen. So it didn't have any impact whether or not the dog was hungry, whether or not the dog needed food. He would salivate when he heard the bell because it was associated with getting something pleasurable, with getting the piece of meat. So interestingly, then Pavlov started not giving the dog the meat. He would either give it intermittently or not give it at all. But even after long periods of time of not getting the meat, if he rang the bell, the dog would still salivate. He would still physiologically respond to the trigger of the bell ringing, even though he wasn't getting the meat. The trigger was still there and was still causing the physiological need and craving, even though he had not gotten meat when the bell rang for long periods of time. And without very conscious unlearning, the dog would be likely to continue that behavior for years. Even if he doesn't hear the bell for years, the next time he hears it, he's going to salivate because the brain systems have wired that physiological response to be connected to a bell ringing. And that's the same thing that happens with triggers and cravings for people with addiction, and why you sometimes see relapse years later, months later, even though there's no possible way they physically are still addicted. There is that psychological subconscious memory system that still has the physiological response linked to those triggers. And so one of the things that I'm sure many of you have seen in recovery residences, just in the recovery community in general, is what we now know is called post-acute withdrawal syndrome. And so this is what happens after detox has ended. And by detox, we're referring to there is no longer the addictive substance in the body. There's no longer the addictive substance sitting on the brain receptors. So the addictive substance is gone. But at this end, the symptoms of acute withdrawal, which you're probably familiar with and we'll talk a little bit more about later, are over. Now there is this syndrome of post-acute withdrawal syndrome and symptoms. And this happens often for many months after the addictive substance is gone out of the brain, out of the body. And it's a result of the brain impairment, the damage that was caused by the addictive substance, and now there is nothing there yet to replace it. The brain has not healed itself, and so the addictive substance is gone. The pleasure message that was going back and forth is gone, and the damage is still there. And so during this period of time, there is a very high risk of relapse, and there is a very high risk of death from overdose due to decreased tolerance if the person were to go back to using at the same level or a similar level to what they did when they had the substance in their system. And the thing that we have to keep in mind is that this biological, physical state can last for years after the last time they actually used the addictive substance. And some of the symptoms that we see of this is low energy, low concentration, poor attention span, poor memory, poor sleep, poor appetite, anxiety, depression, high irritability and restlessness, getting very angry quickly. And so I'm certain that many of you have seen this in people after they've entered into recovery, after detox is over, they're back on the path or they're starting on the path to recovery, and they have all of these sort of symptoms and irritability and quick trigger. And the reality is a lot of that is caused by the damage and the impairment that happened during the addiction. It isn't necessarily a character flaw or a choice or a behavior problem. It's much more likely to be a result of this damage and impairment that was caused by the addictive substance, and now that substance is not there, but the brain has not yet healed itself. So the good news is that the brain is a very remarkable organ, and it does begin to restore its own natural state of communication, and it has brain plasticity is what we refer to this as, the ability for the brain to adapt and form new connections and to heal once things that are causing damage stop. But the thing that we have to keep in mind is that it can take several months. In some cases, it can take years. This is a slow process, and in some cases, not all of the damage is repaired. In some cases, there may be long-term effects. But for most people, the slow healing process does actually occur, and you can actually see it on brain scans, just like we could see the damage that could be done from the addictive substances. When we look at long-term recovery, you can see the healing that happens once the addictive substances are no longer in the brain. So if we look at the far right picture where it says brain recovery with prolonged abstinence, we see on the left the healthy control. So that's the person who is not using or had not used any substances. And then we see next to them a person who had a methamphetamine use disorder. 1 month abstinent, we expose them to a pleasurable sensation or some sort of pleasure trigger. And you will see that their brain really doesn't respond. It responds very minimally. Their pleasure receptors are still impaired. There's still a lot of damage. But that same person at 14 months of abstinence, what you can see is that their pleasure receptors have started to come back, and they are able to experience and to obtain pleasure from that trigger. And then the same thing on the left-hand side, as we looked at earlier, where the ventricles had been significantly increased and the brain matter was decreasing, you see the opposite happening when a person stops using the alcohol. So when we look at the sign, and it's a little bit hard to see on the small screen, but on the larger screen, if you download the slides later, you'll be able to see the difference a little bit more clearly. But what you can see, if we look at the abstinence over 1 year set of slides and go all the way to the bottom, in the left-hand side, it says an MRI 2 months sober, and you can see what the size of the ventricles are. And then that same person at a year sober, the ventricles have become smaller. And what that means is that there is more brain matter. There is more capacity for function and decision making and judgment that is present. There is more functional brain matter present. And so I think that this is really terrific news, that not only can we see the damage and the impairment that the addictive substances do, but we can see the healing that treatment, recovery, and abstinence does. And so we now want to talk about what are some of the medications that we use in order to accommodate this healing, this recovery. And so the first thing that we want to look at is the concept around detoxification. And so a lot of times when we think of detox, we're thinking of abstinence. We're thinking of all opioids, opiate-related, all drugs, all alcohol, completely out of the brain. Absolutely nothing there, and the brain and the body go through physical withdrawal. And what the research actually shows is that this is the least effective method if what we're trying to achieve is long-term recovery. And if what we're trying to achieve is long-term abstinence, this is the least effective way to do it. And a 2011 study showed that as many as 90% of patients who detox, no medications, just complete withdrawal, will relapse within 1 to 2 months unless they get some sort of treatment with medication. And then the unfortunate side effect of that is that we know that some of those people who relapse in those 1 to 2 months, they then overdose because of that decreased tolerance. So the most effective method, the research shows, is to provide medications to address the side effects and the symptoms that come when a person is going through detox, and to address the symptoms of physical withdrawal. So the most effective thing is to transition the individual off of the addictive substance and onto a medication that will address the physical need for the substance and make sure they get behavioral treatment to address learned behaviors, impaired judgment, coping skills, things like that. And so that's your group therapies, your individual therapy, your case management, all of those things alongside medications to address the physical symptoms of withdrawal. That is what's been proven to be the most effective method of entering treatment if what our goal is long-term recovery. And so when we're looking at the medications that help address the symptoms of the physical withdrawal and that help address the addiction, there are 2 classes of medications that are used. The first class is agonists, and these are medications that bind to or sit on top of and get absorbed by those same receptors that used to absorb the addictive substances. And these agonists minimize the symptoms of withdrawal. The other type of medications that are used are called antagonists. And these bind to and completely block those receptors from being able to get any messages. They completely create a barrier, and they do not minimize symptoms of withdrawal, but they do reduce cravings because they block all messages coming in or out. So there's no messages asking for the substance, there's no messages sending in the substance. And so with the medications that are commonly used or out on the market, methadone, which you are probably familiar with, is what's called a full agonist. And what this means is that it fully covers the receptors. It only allows methadone to come into the receptor. Whereas buprenorphine products, that would be your Suboxone, Zubsolv, Subutex, they partially cover the receptors. They don't completely block out natural neurotransmitters. So as the brain begins to heal itself and begins to get back to producing its normal or natural state of pleasure messages naturally, partial agonists, Suboxone, Zubsolv, Subutex, allow those messages to begin to come in and out naturally alongside of these partial agonist medications. Antagonists are naltrexone, so like Vivitrol, Contrave. They knock everything else that is trying to be communicated through those receptors off and completely shut down all communication going in and out of the receptors. So the first one we're going to look at is methadone, and as we said, it's a full agonist. There's quite a few myths around methadone. One is that it's an old drug and it doesn't work. The fact is it is an old drug. It's been prescribed for decades because it works. Methadone maintenance treatment has a success rate of 60 to 90%, and the rate increases the longer the person takes the medication. There's a myth that methadone is just replacing one addiction for another. The fact is, people taking a stable dose of medication, they are physically dependent on it, just like they would be dependent on medication for diabetes or high blood pressure, but they do not experience the characteristics of addiction. And so that's the difference between being addicted to a medication and being physically dependent on a medication. And there are lots of people who are physically dependent on lots of medications for lots of physical diseases. That does not make them addicted to them. The myth is methadone is worse for you than heroin. The fact is methadone can cause constipation. It can cause increased sweating, as can all medications that have an opiate base, but the medication is definitely not worse for you than heroin. So just to review, the methadone neurotransmitters, it does replace it with its own substance. It does not allow any other pleasure messages in or out. And the way that it works is typically set with a very low dosage to begin, and then that is maintained for an extended period of time to allow the brain to heal and stability to be achieved while behavioral treatment takes place. Typically, it requires that people go to an outpatient office either daily, bi-weekly, or weekly to get individual portions for each day of dosage, and the medication must be administered at the same time each day in order to maintain the stability in the brain. The outpatient treatment centers where methadone is dispensed are often referred to as methadone clinics or OTPs, and as you may be aware, these are very highly regulated both federally and at the state level. And so a person who's on methadone, they typically start with a psych eval, they get vital signs taken, there's drug screens, blood draws, EKGs, monitoring symptoms. They start at a very moderate dose. A person does not need to be in withdrawal when they first start methadone. And then over the first 1 to 3 weeks, the dosage gradually increases until the person no longer has any craving for the opiates. And then at that point, a therapeutic dosage is maintained. Typically, the patient is also required to participate in behavioral treatments. And then if a person is going off of methadone, they have to discontinue by tapering off very slowly over weeks or months. And when they are going through that taper, they sometimes use medications for mood and anxiety to address some of the symptoms that might occur when a person is tapering off. So the next medication that we want to talk about are the buprenorphine products. So some of the myths are that Suboxone makes you high. Well, the fact is Suboxone is only a partial agonist, meaning it causes far less euphoria than an opiate such as heroin or oxycodone. The next myth is that you can easily overdose on Suboxone. The fact is, it's actually extremely hard to overdose on Suboxone alone. It has a ceiling effect built into the medication, so the body can only absorb so much. It does have some decreased side effects versus methadone, and some formulations that are buprenorphine only have been shown to be safe in pregnancy. Suboxone, specifically as a name brand drug, is partially buprenorphine and partially naltrexone. And it does require partial withdrawal, typically 12 to 18 hours before beginning Suboxone. It's often prescribed in office-based opioid treatment programs. People can go through induction to be moved from methadone to Suboxone, but it requires very close medical monitoring. It comes in pills or films that dissolve in your mouth. It also comes in patches, but those are very low dose and typically only used for pain management, not opioid addiction treatment. Right now, the research is still a little bit unclear on what is the optimum duration for buprenorphine maintenance. There is a high rate of relapse, as high as 80 to 90%, if it's discontinued in or less than 5 months. So what the research is showing us is that stopping it at or before 5 months is probably not the right duration, but exactly how long is the right duration, we aren't 100% clear on from the research yet. What we do know is that slow tapers, where a person tapers for more than 4 weeks, are much more successful than brief tapers. So typically when a person goes on to Suboxone, they, same as with methadone, get a full evaluation, vital signs, drug screens, blood draws, and when they are in mild opioid withdrawal, Suboxone is given at a low dose. They're monitored to see how they respond, and then an additional dose is given 4 hours later. And then for the next week, they continue on this low to moderate dose, and after a week, the dosage might be increased, and anxiety medications may be used during this period to address any mood or anxious symptoms that occur. But because of the ceiling effect that is built into Suboxone, increasing the dosage above the highest recommended level will not increase a high or increase feelings of well-being. And actually, medical side effects increase, but there's no symptom improvement if you go above the recommended dosage. So the other medication that is often used in addiction treatment is naltrexone. So the brand name for this is Vivitrol, and it is a full agonist medication, and it completely blocks out any communications coming in or going out from those receptors. It's administered via injection every 4 weeks in an outpatient office. It requires that a person be fully detoxed before receiving the injection, which is 7 to 10 days of no use at all. If the person is not fully detoxed and receives a naltrexone shot, it will immediately put them into acute withdrawal, which is not usually life-threatening, but will be very painful. Because of how the medication works, people who have chronic pain and who need to use pain relievers probably shouldn't use naltrexone because they will not be able to receive the benefits of the pain medications if they're on naltrexone. Additionally, there are some known side effects with regard to the liver, kidneys, and intestinal issues. So typically, doctors will not prescribe naltrexone for people with those issues. Naltrexone can be an excellent option for people who go through medically or clinically monitored detox to address those withdrawal symptoms once the medication is gone or once the addictive substance is gone. It can also be an option for people who wish to transition from a daily addiction treatment, such as methadone or Suboxone, but still need a medication to prevent relapse. It does have a higher compliance rate than daily medication because it is a shot. It does pose a risk of overdose fatality after the 3rd week. So as you get closer to the point where the naltrexone is starting to wear off and it's time for your next shot, if you were to use substances, then some research has shown that there is an increased risk of an overdose at that point. It is very effective, but it is used less than the other addictive addiction treatment medications. And so there's been a lot of research and discussion about why that is. And really what we believe is that the reason naltrexone or Vivitrol is used less frequently is because of the full detox requirement. That's a deterrent for many patients. The fact that it's injection is a deterrent not only for patients, but sometimes for providers. And then some providers simply aren't as comfortable with it because of some of the other side effects. They feel a little bit concerned about the lab monitoring that goes along with it. So there's definitely some room for increased education and helping make sure that naltrexone is used when and wherever it can be, because it is so effective when it is used. So the other medication that is used in addiction, which I'm sure all of you are familiar with, is naloxone or Narcan. So one of the things that some people are not aware of is that naloxone and naltrexone, Vivitrol, are based on the same medication, and that's why they sound very similar. Naltrexone, Vivitrol, is very long-acting, and the uptake is slow, whereas the uptake of naloxone, also known as Narcan, is immediate. Naloxone is used to reverse overdoses caused by any opiate-based medication, and it works immediately by instantly kicking off the opiates that are sitting on the brain receptors that are causing the overdose, and then sitting on those receptors itself, not allowing anything else to come in or out of those receptors. Narcan, or naloxone, wears off very quickly, but residual blocking of the receptors from that medication can last up to 24 hours for one dose of Narcan administered. So a combination of medication and behavioral therapies is, like we said before, definitely the most effective intervention to treat opiate use disorders. And this approach reduces relapse. It also reduces overdose. And this approach is used in treating similar diseases. And so when we talk about that, we again think about diseases like heart disease, lung disease, diabetes. We typically advise patients, and we want people to take the medication, but then we also want them to make behavioral changes. We want them to make changes to diet. We want them to make changes to their exercise. And this is really the exact same approach when we're talking about treating the disease of addiction. That yes, we want people to make behavioral changes. No one disputes that. But we also recognize that there is a need to use the medications to treat the disease right alongside it. And just as we don't tell people with heart disease, high blood pressure, high cholesterol, you just need to do the behavioral changes. You just need to change your diet. You just need to increase your exercise. And I don't believe you need any medication to assist you. And if you can't make the behavioral changes to make yourself better, then that's a poor motivation problem. And we just need to really take a step back as a society and even as a recovery community and make sure that we are thinking about addiction the same way. That yes, this is a disease that is exacerbated and made worse by unhealthful decisions, by unhealthful behaviors. But it's also a disease, and the medications that have been shown to be effective in treating it are really the best way, when paired with the behavioral interventions, to treat the disease, with our goal being long-term recovery. And in all diseases like this, just as with someone who has diabetes, someone who has high blood pressure, high cholesterol, the patient may be able to stop using the medications at some point. If their behavioral changes are significant enough, are effective enough, they may be able to go off the medication. And the same thing is true with addiction. And that is our hope, that their behavioral changes will be impactful enough, significant enough, that they'll be able to go off the medication and they won't need to use it for a long period of time or the rest of their life. But we also don't judge a person with diabetes or high cholesterol or high blood pressure if they need to keep taking the medication while continuing to make the behavioral changes. We really want to help make that shift as we look at the disease of addiction, that yes, we're going to support people in making the behavioral changes. We're also going to recognize that some people may need to use medications for short periods of time. Some people may need to use medications for longer periods of time. And each person's path to healing, each person's path to recovery is going to be slightly different, as it is for any diagnosis, as it is for any disease that a person is receiving treatment for. And so we are coming to the end of our presentation today. Does anyone have any questions or comments that they would like to add to the discussion? And if so, please feel free to put your comments in the chat and questions area, and we will address those. We'll give it a couple of minutes.
Jen, it looks like we do have a question coming in from Patrice and Maria Elizabeth.
All right, great.
And while we wait for these, for the participants to finish typing their questions, as we prepare to close out the webinar today, just be aware that there is a short survey link that will pop up as we are finalizing our slides. We do ask that you take just a minute to fill out the survey so that we can know how to more finely tune the educational content that we're providing for you. So Maria writes, how long does a client have to take a medication such as Vivitrol?
And so with Vivitrol, it's really the same situation as with the buprenorphine products. I am not aware of research that is out there that says that the recommended duration is a certain number of months. And typically, it is very individualized to the patient. It may only be, 5-6 months, and so that would be, that number of injections. It may be that some people continue to get shots for several years. It's really sort of dependent on the individual patient and how they're doing and how they're progressing with their behavioral treatments alongside the injections and alongside the medication. Jenna, did you have any other response that you wanted to add to that?
Yes, and that would be that, as with any medication, the course of treatment would be decided between the physician and the patient he's treating or she's treating or they're treating, just like you said. So Patrice writes, this has been very informative. Can you explain how complete blockage of pleasure receptors in the use of methadone does not induce the client to attempt to get high?
So with methadone, so just to sort of clarify, it does completely sit on and block the pleasure receptor, but it actually is sitting on it and sending its own version of a pleasure receptor down. So it's sitting on it, not allowing any other messages to get in, but it is sending a synthetic message down to satisfy or satiate the sort of request or call coming from the receptor for a pleasure message.
And I would just add to that, you're welcome, Patrice. I would just add to that, no, does this stop people from trying to break through the blockade? It does not. In some cases, that is the case. But more often than not, cravings are diminished by methadone. You will see more likely people using other substances such as benzodiazepines or alcohol or sometimes methamphetamine along with methadone. And as you know, we understand that alcohol and benzodiazepines can be very dangerous to use with methadone, and because methadone is such a long-acting agent, that's where much of the danger comes from. But those are outliers that you might see manifested with any substance use disorder, regardless of whether it's opioids or alcohol, where people may take a sidestep in their recovery process as opposed to a step forward or a full lapse backwards.
Thank you. Those are really good points.
So I don't see any other questions coming in. We really appreciated everybody's time and attention. We want to thank you for joining us today. We've enjoyed spending time with you, and we look forward to having more interactive sessions with you. We know that this one was pretty densely packed with information, so it did not really give us much room or time to do a lot of interaction with the participants. We just want you to know that moving forward, we're hoping that it will be more interactive and not just us bombarding you with content. So if you have any additional questions, now would be the time to put them in the chat box. Also, please remember that you can request technical assistance from the Opioid Response Network at any time. I did place the link for submitting a TA request in the chat box at the very beginning of our webinar. ORN does not just serve state targeted response recipients. We actually serve anybody that is serving a population affected by opioids. So you don't have to be a grantee of your state to request this assistance. Finally, as we mentioned before, there is a short survey link that is going to pop up. We do ask that you just take a minute to fill this out so we can gather the information and use that to tweak our remaining webinar sessions that we have planned for you over the duration of the next couple of months. We will be meeting every other week on Wednesday, with the exception of one May meeting that we have scheduled on a Tuesday, and then also with the exception of a July meeting because it falls on the 3rd. And we expect you guys will all be headed off to the beach or to buy fireworks. So we will ensure that that's all taken care of in your calendar invites. Please be sure to register for each one of these webinars individually using the Eventbrite link. And we thank you for joining us. We hope you have a wonderful day. This concludes our webinar.